This is Boomer Life on CL 650.
Let me go home.
Welcome back. This is Boomer Life on CL 650. I'm Joanne Sutton. Thank you for joining us today. In the studio with us is our resident experts with HomeCareAssistance. We have case manager Whitney McMillan joining us today. And we're also saying welcome to Dr. Paul Sugar, an individual who has had a remarkable impact on the lives and deaths of many British Columbians. Dr. Sugar is a palliative care physician. He's co-founded the Paul Sugar Palliative Support Foundation and the Palliative Support Center. Now, their vision was to have a place for people to go where they could feel safe and comfortable to discuss all their needs, fears, hopes, and vulnerabilities. A place where individuals could meet others in similar situations and support each other and share thoughts, information, and share some of their experiences as well. The excellence of his medical care, utmost dedication to his patients, and his availability have been extraordinary. Paul Sugar's practice is not distinguished by the quantity of patients that he assists, but rather by the quality of tender care that he willingly gives them. His time is theirs. Dr. Paul Sugar, I want to say thank you for joining us today.
Thank you for having me.
I understand the next 10, 15 minutes or so of our conversation are going to be based on your approach to palliative care. And I think to start with that, maybe can you help define it? What does palliative care mean and how is it determined?
Well, palliative care means a lot of different things to a lot of people. First of all, I think that one needs to dispel the fear that's associated with palliative care. Palliative care can mean anything from telling somebody that they have somewhere in the order of 3 days or 3 years to live. Basically, it means that you've given them a finality to their lives, and the care they're going to get is going to be focused on giving the time that they have left as much value as possible. And that's what palliative care is supposed to be doing. And it's not a time frame. And a lot of people think palliative care, I've got days, or palliative care, I've got a week or two. It can be years. I have patients who have been on palliative care programs for up to 3-4 years. They have a diagnosis that's a terminal diagnosis, but in fact, they are living their lives productively, at home, comfortably, but they are palliative patients.
So how can you define and how can you explain your personal approach to ensuring that they receive the comfort and direction that they need?
Well, I take my direction from them. Everybody responds differently to the idea that they have a disease that may be terminal. Some people want a lot of detailed care, support, comfort, conversation. Some people are just fine with it. Some people will come and ask for what they need. Some people you need to go to them. And you can read people. You can see what they need. As long as you make yourself available and make them comfortable enough to ask and give them the space and time in which to express their needs, then I think the range of what people need is very different.
So what can you tell us about what that palliative journey might look like?
Well, I guess same sort of thing. It's very different for different people. I mean, I had an elderly man who had esophageal cancer. And when I first approached him, I said, okay, you have this tumor. What do you know about it? And he said, well, I've got this cancer. It's in my swallowing tube. And I said, well, what's going to be the outcome of this disease for you? And he says, well, it's going to kill me. Now, here was someone who was very accepting. He was not very distraught. He was very comfortable with it. On the other hand, I've had patients who are so frightened and so desperate and so panicked, and they don't know where to turn when they're told that they've got a terminal illness. So the journey for both those people is going to be very different. And again, the same thing is true. Providing what's needed for that particular person, individualizing the care that they get according to their need and according to who they are, because people are so very different.
So you must work with an incredible team that would help provide the palliative support and the care that these people need. So once you meet a client and you determine their needs, you find the resources within your center to assist that person.
Our center is non-medical needs. The medical system provides the beds, the investigative equipment, the blood work. We just provide the support. And Marilyn will go into that a little bit later.
Excellent. Can't wait to have that conversation as well. So what's the difference between palliative care and hospice care?
Well, palliative care is, as I say, anything from, I've got palliative patients who have been 3 years, hospice care generally refers to the last few months of life. The patient who's a palliative patient will have investigative procedures, therapeutic procedures, even surgeries, medications that will optimize their life. The hospice patient is going to be someone where you don't do a lot of those investigations. You don't do a lot of aggressive therapy. And there is an acceptance of the fact that life is at an end and that comfort is the biggest issue.
So, Dr. Sugar, can you tell us your values on how important it is to provide home care and palliative care, to have someone stay in their own home?
Well, I was listening to Whitney talking about some of the things that her company provides, and it was echoing a lot of the things that I feel. Unfortunately, it's not always available to people, but the goals are there, and that's great. Some people want to die at home. They want to be around their family, their familiar things, their dog on the bed, their whatever, their family, their familiar surroundings. Some people have a difficult time with the indignities of end-of-life care sometimes. Some people want to be in a hospital bed or a hospice. And again, it is so individual, depending on circumstance. Sometimes families would like to keep somebody at home, and that's what the patient wishes, but they can't afford the care that it would take for that to happen. The family's working, there's nobody at home most of the day to fill the needs. So, the gaps are there. And a lot of things go into making that decision about where end of life is going to take place. Mm-hmm.
So palliative care is not just like a counseling type service.
No.
It's much more than that. There's many, many layers.
It's very aggressive medical care in many cases. Yeah, there's many layers. The palliative care unit is an acute care unit. We do investigations. We send people to endoscopy and surgery, and we diagnose, we try and treat, we look at different treatment options. People on palliative care may be undergoing chemotherapy, may have had a reaction to some of their chemotherapy and need treatment in the palliative care unit for a period of time. But hospice, on the other hand, we're not doing all of that. So that's down at that's the extreme opposite of of the palliative care unit. And there's places in between. Some people are in and out of the hospital to treat intercurrent issues that come up, and then they go home again. And it's not like you're admitted to the palliative care unit and you stay there until you're ready for hospice. You come to the palliative care unit, you get treated for what the complication or issue is. You go home, you live your life, you may work, you may do all the things that you do, enjoy your family, go for walks, whatever. Mm-hmm. And then as things decline for the palliative patient, the direction of care changes.
What are some of the challenges that you face with palliative care?
Well, I think that the support that people need, the navigation, the
advocacy.
Advocacy is a big one. Advocacy is extremely important. It's an overburdened system, and if you're not speaking up about the things that you need, you may get sidelined. And the system tries to accommodate, but there isn't enough. There isn't enough home care. There aren't enough home care nurses. And I think the system is trying to correct those things, but we're nowhere near that yet. We have a limited amount of resources. We have hospitals that are very expensive to put somebody in a hospital bed. It costs a lot less to keep them at home, but we don't have some things in place to keep them at home. So we have people juggling those issues that know a lot more about it than I do. But what I notice from my point of view is that there's not enough home care out there.
Thus, the marriage of our guest today from HomeCareAssistance and Dr. Paul Sugar from the Palliative Care Support Foundation. We'll be talking in more detail about how this marriage works and how you all work together. Thank you for your input so far, Dr. Sugar. You are listening to Boomer Life on CL 650. I'm joined in studio this afternoon by Dr. Paul Sugar, and we're talking about palliative care. We're also joined by Whitney McMillan, who's a case manager with HomeCareAssistance out of West Vancouver. If you want more information about our topic today or the services provided, please visit their website, homecareassistancevancouver.ca. We're about to meet the other founding member of the Paul Sugar Palliative Support Foundation next, with a fresh perspective on how you and your loved ones can benefit from their support and services. That's all coming up next on Boomer Life on CL 650.
Celebrating the baby boomer lifestyle. This is Boomer Life on CL 650.